I think we are ready to get started. Hello, everyone. Good morning, good afternoon, and good evening, wherever you're calling in from. My name is Emily Hirata, and I am the chair of ADRA's Health Technical Learning Lab, otherwise known as the HTLL, an internal ADRA working group focused on health, nutrition, and WASH. We would like to welcome you to our webinar today on using a data-driven approach for effective behavior change work. During this hour, we will explore how aid workers can leverage data on the prevalence of promoted behaviors, barriers, and enabling factors to shape the focus of their social and behavior change, or SBC, activities. Drawing on best practices from ADRA Yemen's SBC approach, we will see how meaningful use of relevant SBC data can increase the impact of health, nutrition, and WASH programming, while providing examples and practical guidance on how to replicate this successful approach in other contexts. We are joined by three speakers today, Raghib Fadel, Rasha Sakaria, and Peter Schmid. Raghib Fadel works as SBC coordinator for ADRA Yemen. For the past 3 years, he has led the implementation of ADRA's data-driven SBC approach. Rasha Sakaria is a monitoring and evaluation officer for ADRA Yemen, who has supported ADRA in integrating quality standards into M&E processes. She has played a crucial role in ADRA Yemen's SBC survey methodology design and management. Peter Schmid works as a behavior change consultant focusing on helping organizations understand key enablers and barriers to change and to design effective behavior change strategies. He has provided technical support to teams in 12 countries, including to ADRA Yemen, which he has been advising on for several years. Now, just a few housekeeping items to keep in mind. This webinar is being recorded. If you are not comfortable with this, you may disconnect now and are welcome to view the recording at a later time on our ADRA TLL YouTube site. All mics should be muted except for those that are presenting. However, if you have questions, which we do encourage, please feel free to post them in the chat and we will try to get to them later on during the Q&A portion of today's webinar. Now, without further ado, I would like to hand it over to my colleagues Raghib, Rasha, and Peter. The floor is yours.
Thank you, Emily, for this introduce, and thank you everyone for joining our SBC webinars for using data-driven approach for effective behavior change work. My name is Raghib Fadl. I am SBC coordinator for ADRA Yemen. This webinar is for ADRA Yemen and supported by ADRA International, and my colleagues, Mr. Peter Schmid, he is our SBC consultant, and Ms. Rasha Zakaria, she is our monitoring and evaluation officer for ADRA Yemen. This webinar is for ADRA Yemen for PHA-funded YAMLI project. And as what we'll ahead use for you, we will present a brief introduce to our SBC work and how this will be presented by me, and how do we understand data-driven approach to SBC, and this slides will be presented by SBC coordinator, SBC consultant Peter, and also introducing ADRA's annual SBC survey. This also will be presented by SBC consultant Peter. And also SBC survey methodology. This will be presented by our SBC, our monitoring and evaluation officer, Ms. Rasha Zakaria. And also process to designing SBC survey and using their data. This will be presented by our SBC consultant, Mr. Peter Schmid. And also examples of how data keeps shaping our SBC work also will present by our SBC consultant, Mr. Peter, and we will give you space to sharing your comments, experience, and questions after we will finish this webinars. And also, if you have any questions, you can add it to our chart and you can ask also. Yeah, now we will get to the background. As you know that for SBC team, we are working with ADRA Yemen since 2019. We have 5 years experience to work with ADRA Yemen in SBC approach. In Yemen, like 18 and 2 million people need humanitarian aid. This is to the economic situation, poor economic situation in Yemen, also level of acute and chronic malnutrition and low poor education. And also other provide BHA funded multi-sectoral aid like health, nutrition, wash, SPC and protection, and also key SPC activities include strengthening of SPC capacity of frontline workers. When we say strengthening of SPC capacity building for frontline workers, we mean our community health and nutrition volunteers and health workers, and we provide trainings like 3 days on SPC communication and facilitation skills training, East approach trainings, and knowledge trainings for our health workers and community health and nutrition volunteers, and coaching monthly workshop for CHMVs, and these activities led by our health facility staff to support our CHMVs and support them, and focusing about strengths and weaknesses for our CHMVs, and WhatsApp group support this group for CHMVs, the community health and nutrition volunteers, to can share with them all things related to our work. And also individual counseling and group sessions for women. This counseling, it has been in the health facility from the midwife, and also home to home by our community health and nutrition volunteers during home visits, during group sessions. And also we include a group sessions with the husband. This group session is conducting by our main health facility staff to the main around the third zone and two zone around the health facilities that we are supporting. And also use videos in health facility during household visit and WhatsApp group. This videos is animation videos to play a big role to the health facility. We are displayed in the screening in all the health facility that ADRA staff ADRA is supporting, and during the CHMVs, they can using these videos around their home visits and group sessions. And now we will move to the next slide. Also, ADRA has operated in the 2017. We are supporting many health facilities. And now we will go to the other slide with our SBC consultant, Mr. Peter Schmidt. Over to you, Mr. Peter.
Thank you for the introduction, and also many thanks to Emily and your colleagues for hosting the webinar. So Rahab has walked us through what we are doing in Yemen. And I would always argue that it's maybe even more important, not just like what kind of activities, what kind of behavioral change activities an organization implements, but rather what do these activities focus on? What do they communicate? What do they help with? Before I dive into the details of like what do we actually focus on, what is our SBC work about, and especially what is informing our SBC work, I would like to reflect a little bit on the prevalent, let's say, way how behavioral change work has been reflected in the language that is used in different documents. I will be speaking mainly about like from the experience from Yemen that I have supported for the past 5 years, but many of the things that I will be saying, they also remind me of my experience from other countries. So perhaps those of you who are joining from other countries, maybe that some of the points that I will be now mentioning, they will also resonate with your experience. So the way how different documents, including, for example, official guidance, policy documents are talking about SBC, the way how people talk about behavioral change, and the way how activities are designed or described, how they are implemented. And it doesn't really matter whether these are activities of NGOs or some documents of the ministries or some like larger humanitarian or development programs. they have all many of them, and I'm very much hoping that it's like a decreasing trend. Many of them have one thing in common, and that is that they approach behavioral change as a matter of education and awareness raising. These are some of the very common sentences or common opinions that you can hear frequently when people talk about people, different documents are talking about behavioral change. Basically, the perception is that if you want to be changing people's behavior, you need to be educating them. Yesterday I returned from Yemen, and I even heard from one person this sentence: "We need to be distributing more messages so that we have a better impact." And you can notice that lots of efforts, like lots of talking, lots of money is spent on activities that are basically telling people what they should be doing and why they should be doing it because it's good for them. So there are many IEC materials, many videos, social media posts, theaters, awareness raising sessions, radio messages, international days that consume really like a huge amount of funding and huge amount of effort of many people. But what kind of the key thing that they communicate is that they are just recommending people what they should be doing and why they should be doing it. So they are like focusing on increasing people's knowledge. And for us, the key question is this really what people need the most? Is this what will help them to adopt the different practices related to health, related to hygiene, related to nutrition? Because from the data that we have, we can see that knowledge is definitely important, but there are many people who have knowledge about all these behaviors. They know very well why they should be doing them and what could be the benefits of it, but they still don't practice these behaviors. And so those of you who perhaps know me, you know that I'm a bit, I have a slight allergy towards like seeing behavioral change as a matter of educating people or as a matter of raising their awareness and increasing their knowledge. Because I know that this like education-oriented approach has, for at least like two good reasons, very limited effectiveness. First of all, there are many other factors that influence whether people do or do not influence a behavior, adopt a behavior. So, for example, with my colleagues in Yemen, we were discussing just last weeks that women are encouraged to deliver in a health facility, and they know that there are many advantages of delivering in a health facility. But if health facilities are opened only for several hours per day, it's quite unlikely they could deliver there. At the same time, if they don't have any means like how to get to the health facility, this knowledge will also not help them. And there are many other reasons, like many other barriers to change that have very little to do with people's knowledge. And so just having the knowledge, it's not really going to bring the change. Even if people have the knowledge, they don't necessarily believe in it. You might still recall from the recent COVID pandemic that many people were aware of or heard that vaccinations are meant to be good for them, but they thought something different. They didn't believe in it. They had a different opinion. So even if someone tells you that he or she has the given knowledge, it really doesn't mean that this is something that the person is willing to act upon. So we in ADRA, one of my first tasks when I started supporting the team of the team at the time was that we had to first internally, like among our own colleagues, to reject this like traditional approach to behavioral change and to build kind of new, different theory of change, like different way how we want to like achieve a change in people's behavior. If I would simplify our current theory of change, we know what is needed the most, like the key precondition is that we understand why people do or do not adopt the promoted behaviors. And then that we have people in the community, such as health workers or volunteers, that are respected by the community members and that have a good technical and especially behavioral change competencies. So like all the soft skills that are needed in order to be able to really like enable, help, support people to adopt the promoted behaviors. If these two preconditions are in place, then we can implement activities. But these activities, they don't focus on increasing people's knowledge primarily. They focus on lowering the different barriers that hinder behavior change and on strengthening what is helping people to adopt behavior. Well, and if these activities are successful, then what they achieve is that fewer people experience these barriers and more people experience the enabling factors. And this is what we believe will lead to the higher adoption of promoted behaviors. This is also the theory that we have been monitoring, or like this, its validity we were testing for the past 4 years by so-called SBC surveys, and that is the main topic that I would like to talk to you today about. So if we are saying that we want to focus on lowering barriers and strengthening the enabling factors, we need to know what these barriers and what these enablers are. So what is informing our SBC programming? What is telling us what is actually like hindering change or what could facilitate the change? I think the first few points will be something that many other organizations are doing. So we have conducted qualitative formative research. We used some existing data from ADRA. We also used qualitative insights from the volunteers, from health workers. We also reviewed information provided by other organizations. But the key kind of difficulty that we were facing is that each behavior is influenced by actually many different barriers. If we would simplify it and we would say that we promote about 14 behaviors, which is what we are promoting currently, and if we would say that each behavior is influenced by 7 different determinants, either like barriers or enabling factors, which is still a very modest number because usually qualitative research reveals many more determinants, then there would be about 100 determinants that we have to address. Now, the funding that we have from BHA, it's a humanitarian funding, so where there is, of course, great emphasis on efficiency, and we just don't have the capacity to be addressing 100 different determinants. So the question is, which one should we focus on? How should we prioritize? Because we wanted to make sure that our programming is based on evidence, but at the same time, we knew that we cannot rely only on qualitative information, because for the qualitative information, it often wasn't clear just just how prevalent the different barriers are and whether is it really worth focusing on them. So that's why in 2011 we started conducting so-called SBC surveys. The SBC surveys are quantitative surveys that we conducted annually. First of all, to understand which barriers are experienced by most women, because our activities mainly focus on women, on mothers of young children. Also, to what extent they experience any enabling factors. What are the adoption rate for the different behaviors? This is something that told us how effective our work is, like to what extent we are managed to increase the adoption rates and reduce the different barriers. This is also telling us, because we have more data on the prevalence of barriers and the enabling factors, this is informing us what our activities should focus on or like what we prioritize. And these surveys were also quite influential in helping us to choose the most suitable communication channels. So just to sum up, these surveys, quantitative surveys, they help us to ensure that our work is driven like really primarily by data and not by our assumptions. And sometimes we can have assumptions even when we have lots of qualitative research data. Please don't get me wrong, I'm a big fan of qualitative research and I very well understand its value. I just also know that if we rely only on qualitative data, we might sometimes incorrectly focus on something where in case we would also have the quantitative insights, we would realize that actually the given barrier is, for example, experienced only by very few women. It happened to me when I work in India. I will give you an example. the team that I was supporting believed that there was quite a widespread belief that pregnant women think that they cannot eat lemon and some other foods. But it's just like not like healthy or like not desired during pregnancy. And then and there was like a interest to do some communication around this. But then when we tested it as a part of the quantitative survey, we realized that actually this is opinion that only few percentage of the targeted women have. And so if we would focus our energy on addressing this opinion, in fact, it would be quite like an inefficient use of our time and of the program's money. In our experience, these quantitative surveys, they were for us much more useful than the way how CAP surveys, so knowledge, attitudes, and practices surveys, are usually designed. It is mainly because CAP surveys can be great if they are designed really well and if they don't focus primarily on measuring adoption and measuring knowledge, which has been my experience with many CAP surveys where there was just not really enough emphasis on understanding how prevalent the different barriers were, because the main barriers that were, or supposed barriers that were measured, were just knowledge, whether people have the knowledge and then whether they adopt the behavior. Whereas the SBC surveys, they enable us to really assess like much wider scope of factors that influence whether people do or do not adopt the given behavior. So let me just introduce you the SBC surveys in a little bit greater detail, including some practical examples. But before I do so, I would like to pass the word to my colleague Rasha. It will give you a bit a technical background about what is the methodology of these surveys. So, Rasha, if you are here with us, please make sure that you unmute your mic, and if you could explain to us the SBC survey methodology.
Oh, is
Hello,
my
Rasha,
voice
we can
clear?
hear you. Yes, go ahead, please.
Hello, everyone. I am Rasha Zakaria.
Hello, Rasha, please go ahead.
Yes, I am Rasha Zakaria, male officer. And now I will share the methodology behind the 2024 SBC survey. So in this methodology, I will cover how we selected our respondents, the sampling method used, and the importance of conducting the survey at the constant time each year. So let's take an overview of the methodology. Respondent, 445 mothers of children under 2 years living in 3 targeted governorates. So in this survey, we focus about a specific group, which are mothers of children under 2. In point 2, randomly selected using cluster sampling. And the sample in each governorate is proportional to the number of targeted women in each governorate. So, to ensure that the reliability of our results, this means that we should identify the clusters within the governorates and randomly selected models from these clusters. In point 4, the data has a 95% confidence level with a margin of error of 4.6%. And in the point 5, we use the COBA questionnaire to reduce the risk of biases. So in the SBC survey, we use in general the COBA data collection tools to enhance the quality of our data. In point 6, to ensure the comparability of data from different years, which means so in each year, whenever we conducted the SBC survey, we follow several key practices. And here we have 3 practices which we are conducting whenever we conduct the SBC survey. The first practice, conduct the survey in the same part of year, which is October. So due to the regular timing, it helps maintain the integrity of the survey processes, which could arise from conducting survey during different periods. So that's why in each year we conduct the SBC survey in October. In the second practice, use the same sampling methodology. So we use the same sampling methodology each year, which is cluster sampling. And third practice, the key question remains the same. So we ensure that our key questions remain the same each year, which is important to tracking the change in attitude and behaviors over time, which we can directly compare the responses and allowing us to measure the progress. So we come to the end of this section. Thank you all for the listening, and over to you, Mr. Peter.
Thank you very much, Rasha. I think that many of you who are familiar with conducting quantitative surveys, you can see that this is like quite a standard methodology for population-based quantitative surveys. This is, I think, something that many of you are familiar with. So what I would like to focus on in the next minutes is primarily talking about like how do we design the surveys, like what is informing the design of the content and what makes it different, for example, from the traditional CAP surveys that I mentioned earlier. So when we are designing SBC surveys, for us the two key questions are which barriers or enablers do we need to study, and which data we don't need anymore. For example, data that we collected during the previous surveys, but we just found that there is no need for them anymore. So how do we answer these two questions? We always review the findings from the previous surveys, because sometimes for example, when we see already for 2 consecutive years that, for example, people have very high level of knowledge about something, we don't ask about it anymore. We just drop it because there's like a good evidence that the knowledge is there. So once we, for example, find out that something certain, for example, something what someone thought might be a barrier actually is experienced by very few women, and there is like little reason to be thinking that this could like somehow increase significantly, or if we see that like certain like enabling factor is like very high, again, for example, we have seen it in the previous surveys, then it's helping us simply to see like what we should kind of continue tracking and what can we drop. Then throughout like the year, like since that like the preceding year, we are collecting any insight, for example, from our own colleagues, from the community health and nutrition volunteers, and from the health facility staff that are giving us like some hints, some qualitative insights into what could be perhaps like some barriers or some enabling factors that we perhaps like haven't realized earlier that could be like hindering the desired change. We are also looking at what kind of activities we want to implement and what information we need in order to design them well and to decide like which activities should be prioritized. So there are some changes that we make to the survey, mainly those like focusing on the prevalence of barriers. But the questions that are tracking the effectiveness of our work, so mainly the questions related to the adoption rates, they remain the same, just so that we are able to compare the data like across time. And of course, we have the process of designing SBC surveys include like lots of training on enumerators, pre-testing, different adjustments, supervision, just to make sure that we are really able to rely on the data. And once we get the data, then what's next? Like what's the process? Well, as usual, we draft the report, including very specific, like practical recommendation related to all the key findings, and we develop an action plan that is saying like who exactly will do what by when in order to like use the findings. Then we present and discuss the drafted findings and recommendations with our colleagues and also with the community health and nutrition volunteers. We incorporate their feedback, finalize the report, finalize the action plan, and then we also update like any tools that we are using to support the community health and nutrition volunteers. So for us, the key tool is so-called tip sheets, which are like 2-page guidance documents that are developed per each behavior and that are telling the volunteers what they should focus on, like for example, which barriers are most prevalent and what type of support could actually like help women in overcoming the barriers. Then we organize workshops to discuss the key changes that happened like as a result of the findings and recommendations of the annual SBC surveys with the volunteers and with the health workers, so that they also like know what they should be doing differently. And then we are following up on the action plan to ensure that we like address the most prevalent barriers and that we are strengthening the enabling factors. And this process, like these six steps, they are repeated every year, and they are in fact like steering the focus of the work that we are doing. They are kind of making sure that the ship that is carrying like all our like SBC efforts is heading in the right direction. And when I say in the right direction, it means like in the direction that is helping most people to find it easier for them and more motivating for them to be adopting the different health, nutrition, and hygiene practices that we promote. Now, this was about the process, and I think that perhaps you would appreciate seeing some examples of how does the different data and how do the different recommendations actually like shape our programming in practice. Let me illustrate it using a few examples. So how is such data from the SBC surveys helping us to choose the communication channels that we are using? I will always present few findings and then I will show you how we use the findings. One of the findings was that about more than a quarter of women are illiterate. These rates were much higher among mothers-in-law. We knew that very few women listen to radio regularly. On the other hand, we knew that quite significantly increasing proportion of women are using WhatsApp frequently, and that community health and nutrition volunteers are the most common source of health-related information, and that women are like either like moderately to highly satisfied with the work that with the support that these volunteers provide. So how has this data influenced what we are doing? First of all, we decided that we will not be using like any or many IEC information, education, communication materials that include written text, simply because we would exclude quite a large proportion of the target group members. So we are focusing primarily on like spoken and visual communication, so like interpersonal communication, videos, voice messages. This was quite a big change initially because there was a big reliance on just using materials that had text included. We also completely dropped the idea of using any radio-based communication, even though on different occasions we were encouraged by different people to work on it. And we scale up, and we are still scaling up mobile phone-based behavioral change messaging. And we also continued supporting the volunteers' technical and SBC skills because we saw that they are really like the key channel that can help women to overcome some of the barriers. So this is how the data shaped how we communicate the different things that could be helping women or other caregivers to adopt the promoted behaviors. Now let's have a look at a few examples of how the data shape the way how we are helping women to adopt some of the behaviors. So the first behavior concerns women consuming extra calories during pregnancy. We saw that this is not a very common behavior. It's also not like super uncommon. We knew that there is a very high awareness that eating more during pregnancy is better. There was no issue with lacking knowledge. And we also learned that the main reasons why many women actually know about it, that it's good for them, or even like agree with it, but why in fact like 60% less women do so, is that it's primarily because during pregnancy they are facing like lacking appetite and nausea. to some extent also lacking food. So for us, this meant that we can almost completely drop this like any general awareness raising about the importance of consuming extra calories during pregnancy, simply because it's high and we would just be like wasting our like efforts and BHA's money if we just like kept repeating something that women already know. And we realized that we need to focus on like finding ways to help overcome women the two key barriers, which was nausea and lacking appetite. So instead of doing general awareness raising, we just focus on like these like two very specific barriers to change. Let's have a look at another behavior, early initiation of breastfeeding. Well, in last year, when we measured 100% of women, they said they agree that colostrum is healthy and that it should be fed. This number was also a result like of all the efforts from the previous years, and that also many women initiated breastfeeding within 1 hour of birth. And those who haven't done it so, it was because the baby was born by cesarean section, or because the mother didn't feel well after delivery, or because the baby had to receive health care, like urgent health care, and just wasn't with the baby, like with the mother within the first hour after delivery. So what it meant for us is that we realized that actually the reasons why the remaining 16% of women do not follow this behavior, it has little to do with their knowledge or with their willingness to practice the behavior. It is because simply factors that were like in fact largely beyond their control. So we realized that instead of just focusing on mothers, we need to focus much more on strengthening the health workers' support to early initiation of breastfeeding after delivery. Because if they provide more support, like perhaps better or like more timely support, this is actually what can increase the proportion. It can increase it much more than if we would be focusing on mothers. Another example, exclusive breastfeeding. 70% of children were exclusively breastfed. It's a great result. Some like 4 years ago, it was close to 8%. Then it was like gradually increasing. 9 out of 10 women saw that feeding only breast milk to children is enough. But a little bit conflicting information, but I think it makes sense. 15% of women saw that on hot days, actually feeding breast milk is not enough, and children should also receive some water. So it seems that the hot days were treated a bit differently than ordinary days. And also more than a third of women, they were encouraged by household members to feed other fluids or foods. So we could see that there was a conflict between like what the women sought and between what some other household members recommended to them. And less than a third of women, they also have experienced different breastfeeding difficulties. So this is the data that we had, and now how it shaped the work that the support that we provide. First of all, we knew that we have to tackle the perception that a child will be either hungry or especially thirsty if it receives only breast milk. We also have to make sure that household members are more supportive to exclusive breastfeeding, and we had to improve the availability and usage of breastfeeding counseling services. So again, no general awareness raising about the importance of that exclusive breastfeeding is good for you and so on. It was really about focusing on these three priorities. Now, example from a different sector, from the water sector, regarding treating water using chlorine. Treating water using chlorine was the most common water treatment method. A little bit more than a quarter of households practice it. And those that were not using it, actually, we originally thought that this is because they don't like the taste of chlorine. We saw that this is the most prevalent barrier. But when we look into this behavior, we knew that actually the most prevalent barrier was that many women thought that the water that they are using is already safe and that there is no need to treat it. Which in some instances, it was possible the water is safe. In other instances, the water we knew was not safe, and it was just like women's perception. It's just fine to be drinking this water. The other barrier was like financial barrier. Then another barrier was that some women saw that their household members would disapprove of using chlorine. then some women saw that chlorine is bad for their health. And actually, the topic that we saw, the barrier, that we thought it would be like the most influential one, came out only on the 5th place. Yeah? The perception that water treated by chlorine has a bad taste. And so instead of just focusing on the issue of taste, we knew that we have to focus much more on the perception that there is no need to treat water and that chlorine is harmful to health. And of course, we also had to focus on the issue of chlorine's affordability. Then I think the last example, it is like just illustrating how the data is driving what we are doing relates to minimum meal frequency. It will be a bit different example. When we collected and analyzed the data on minimum meal frequency, we saw that we are making pretty good progress when it comes to the meal frequency of breastfed children, but that we are doing quite poorly when it comes to the minimum meal frequency of non-breastfed children. It was especially concerning because the average duration of breastfeeding was only about 9 months. So what came out of this data very clearly is that we really have to focus much more on improving the meal frequency of non-breastfed children. This is what requires that when we talk about minimum meal frequency, this is what requires the most attention. Now, what were the results of the SBC work? If you are terrified by this chart, you don't have to be terrified. Just look at the direction in which all these colorful lines are going. You will see that most of these lines are going up, and this is what we have been very happy about. That actually the adoption rates have been quite steadily increasing. Not for all the behaviors, like for example, during this year's survey, it was for 12 out of 14 behaviors, which of course means that there are some gaps. Yeah? We definitely haven't managed everything, but generally the trend has been very positive. To illustrate it by more specific numbers, extra calories during pregnancy has increased from 13 to 34%. Early initiation of breastfeeding from 43 to almost double. Exclusive breastfeeding from 8.5 to almost 70%. Children's minimum diversity, it's a challenging topic. It went from 4.9 to close to 20%, which of course we know it is still relatively low, but if you look at it, it's like 400% or 4 times bigger increase. Hand washing actually went down. There are some gaps that we have to focus on more. Minimum meal frequency also went slightly down. When we look at the data in what the proportion of people that experience specific barriers, there was also quite significant reductions in the proportion of women that experience the factors that prevent them from adopting the different behaviors. So just to summarize, we are very happy with all the achievements. At the same time, we still know that there is a significant room for improvement. Yes, some behaviors, they went downhill. For other behaviors, there is still lots to improve, especially when it comes, for example, to the meal frequency and dietary diversity. But overall, I would allow myself to say that the work that we have been doing in Yemen, the SBC work, has been quite successful. And the key question always for me has been, okay, so what's the key to success? What has contributed to it the most? And I personally believe that the key to success has been the fact that we were systematically assessing what exactly is preventing women from adopting the behaviors, and not just on their in a qualitative way, but really looking just how many women experience this barrier. Is it just few percent of women, or is this dozens of percent of women? And then we were focusing on the most prevalent barriers. And I really believe that this quantitative aspect is what help us to make sure that we are able to prioritize well and to have a good impact. Now, if you ask me, are you able to prove it that this was the main reason? I would answer no. I'm definitely not able to prove it, because in order to prove it, we would need to be doing a randomized control trial where half of the population would be just exposed to the kind of more traditional approach to changing people's behavior, and the other half would be exposed to the approach that I presented, which I think we can agree that in a context of Yemen, it would not be very ethical thing to do. But it's my just the best possible explanation of why the results are as they are. If you would like to learn more about the work that we have been doing, about the approach, you are welcome to contact Raheb, who has been already for several years the steady lead of all this work, who has been implementing day by day everything that we agreed on. So Rahab can share with you also some of these resources, some of that are displayed here on the images. First of all, if you would like to see example of what an SBC survey report look like, he can share with you this document. It will be finalized just in the next few days. I'm still waiting to receive and to address some of the last comments from some colleagues. And we also published recently, about a year ago, a short publication on our SBC best practices. And this summer, we also prepared a new version of the SBC strategy that was now also updated with the latest data. So this is something that we are happy to share with you. Please feel free to reach out to Raheb. Raheb, if I can ask you, please also write your email in the chat so that anyone can use the email if needed. And then let's move to any comments that you have, perhaps anything related to sharing your experience. And if you have any questions, either for Raheb or Rasha or me, feel free to ask them.
Thank you so much, Raghib, Rasha, and Peter for that insightful presentation. And thanks especially for showing us examples of the results that you've gotten from the SBC surveys that you've done, as it gives us really great encouragement that SBC so it's really helpful, very insightful. At this time, as you said, let's jump right in. We do have a few questions that have come in, so I would like to address those first if we can. And I'll just read them out. So if one of our presenters can answer the questions, we'll try to get through everything. If we can't, then we'll try to provide answers to the rest of the questions in the follow-up email that we will be sending out to all of the registrants. But to get us started, the first question that I want to pose to our presenters here is, it says, I see that the SBC quantitative data gathering takes place yearly. Is it realistic to expect that we could expect to change behaviors in less than 1 year? For example, in projects that last 12 to 18 months, is that time period too short to expect meaningful behavior change?
Well, I think that some of the results I showed you. You can see that actually there were changes year by year, and I think that the question of whether we can manage to change people's behavior within 12 to 18 months, I would say it depends on how well you understand why people do not practice the behavior. If you really understand very well just what exactly is preventing people from practicing the behavior, and if you manage then to help them, then yes, you can achieve change. You can just imagine it, if I would like to help you, if you tell me, okay, you have some difficulties in life and I would be supposed to help you. If I understand what exactly could help you the most in your life situation, then yeah, maybe I can influence it. But if I will just acting based on my assumptions, then likely not. And with our SBC work, it's pretty much the same.
Thank you for that, Peter. Next question is, do you utilize behavior change tactics to determine the most effective communication channels or interventions for addressing specific drivers?
Behavioral change tactics to the I don't know what would you mean by using behavioral change tactics. I think that we want to be using communication channels that people trust the most and that can reach the most people. But I would say that I would argue a little bit that it's more important what the channel's communicating rather than which channels we are using, whether is it.
Maybe maybe the person who provided that comment can clarify a little bit more. But thank you for what you've uh, for that answer. In the meantime, let's move to the next question. What is the best M&E tool or meal tool to measure the impact of SBC interventions, and how often should we do assessments to monitor the progress?
I will maybe also pass the word to Rasha. If Rasha, what would you think about, what would be your opinion about this?
Yes, about the first comment.
Emily, if you can repeat the question, please.
Can you repeat, please?
Yes, absolutely. The question is, what is the best meal tool to measure the impact of SBC interventions, and how often should we do assessments to monitor the progress?
Well, I think to selecting the best monitoring and evaluation tool for assessing the impact of social behavior change intervention, it depends on the various factors, including the specific objectives of the intervention and the target population and available resources. So the M&E tools we can use like the survey questionnaires, which have the purpose and use like the purpose of collective quantitative data and the use of the intervention survey, and also the focus group discussion, key informant interview, and observation, and mobile data collection tools. So I hope you got your answer.
Maybe if I can just add to it, if your budget
So in
allows,
summary, let me summarize. In the combination of the quantitative and qualitative methods, along with the clear timeline for the assessment and regular monitoring and adaptive management to effectiveness of these interventions.
Thank you, Rasha. I actually wanted to say the same, that I think like the marriage of like qualitative and quantitative data, where the quantitative data just tells you like what's the proportion of like people that experience that have adopted the given behavior, also to what extent you reduce the prevalence of the barriers, and then alongside with some qualitative insights, that are just like more like broadly like looking at what changes in people's lives the intervention brought. I think it's the best.
Thank you for that. Another really interesting question just came in. What strategies are there to ensure the behaviors are sustained? As I've noticed, there was a sort of decline in hand washing, for example.
Well, always when I think about the sustainability of behaviors, I'm always asking myself, okay, so like what needs to be in place so that this given behavior can be sustained. Yeah? And I think that for really perhaps all behaviors, we are able to like brainstorm and especially like talk to people about just what needs to be in place so that they can continue practicing this behavior. So, for example, for hand washing, it can mean that people like keep having access to soap and to water. That, for example, the decision makers, in the Yemeni context, like husbands, that they see the like value in purchasing soap, despite, for example, limited budgets. There can be like many additional factors, but I would just encourage you always really just to brainstorm with the people that you support, really what needs to be in place so that they are able to keep practicing the behavior. And then this will like tell you what should you focus on in order to sustain the behavioral change. Rab, is there anything you would like to add, or Rasha?
No, nothing from my side.
Okay, next question. This question actually, I think, is a really important one because not everybody is very familiar with SBC or even meal data collection. So the question is, can I ask what a Kobo e-questionnaire is and how it overcomes bias? Are people without smartphones able to respond?
So I will pass this question to Rasha. She's best positioned.
Yes, a Kobo questionnaire is like a digital form or survey tool created to using a Kobo toolbox, which is a platform to design the data collection and often it's using by the M&E team. So how we can overcome the biases in using the COBO tools, like to allow the survey to be in multiple ways, like mobile phone, tablets, or computers. This flexibility can help reach different populations, reducing the risk of biases that come from restriction access to assistive technology or platforms. And also the COBO toolbox can be collected data anonymously, which can help to reduce the social disability biases. And that's it. Thank you.
Thank you. Thank you, Rasha. I think we have time for maybe just one or two more questions. This one is a bit more of a historical question. So Peter, you might be the best to respond to this. How old is the SBC approach, and what is the most successful achievement of it so far from your experience?
Good question. Well, it has developed. So before you were talking about like IEC, about like information, education, communication, which was to a large extent like quite top down, just knowledge transfer that rely on the assumption that if we educate people, this will change their behavior. I think that all of us know like what we should be doing, and we can ask ourselves like just how much we are doing it. When it comes to exercising, healthy diets, and like sleeping enough, not working too much, and so on. So we know the limits of like education and raising knowledge, and this has been realized in the sector. I don't know if maybe like 15 years ago, I registered like more and more like talk about SBC. Sometimes it's like confused with SBC communication, which again, to my opinion, is focusing really too much on just like communicating knowledge. I think that SBC is about much more than communication. So yeah, there have been definitely like some development, and what has been most successful. It's hard to say. You could argue that during COVID, like within several days or within several weeks, suddenly you had like billions of people worldwide like facing wearing masks and getting vaccinated and so on. So maybe you could say that like globally that has been like the most successful behavioral change intervention. But I would say that simply the most really successful interventions are those where the people who promote the behaviors, where they are not doing it in a top-down manner, where they are really using like discussions-based approaches to understand what's holding people back and what would help them the most. Then they are not just like having the information about what will help the most, but they are actually focusing on it. Sometimes there is a big difference between just have a formative research report and actually acting upon it. So yeah, I would say these are the most successful interventions, and I cannot say like which one was the most successful one in the world. I don't have the full overview.
Thank you for that, Peter. Sorry to put you on the spot with a difficult question. That is unfortunately all the time that we have for today. Because we are already past the hour. I want to thank all three of our presenters for taking the time to share their knowledge and experience with us. We also would really like to thank all of you who have chosen to attend our event today, as we hope you've gained some insightful learnings. In the coming days, you will receive an email. Everybody who's registered will receive an email with a recording of today's webinar, as well as a satisfaction survey. Please take it if you can. It helps us with future webinars. You'll also receive in that email the presentation slides, answers to the remaining questions, as well as Ragheb's email from the slides so that you can contact him for more information. So please be on the lookout for that email. Thank you again, and warm wishes to all. Bye, everyone.
Bye,
Bye,
everyone.
everyone. Good day.
Good day.